Hey guys, how's it going? This is FixerMed. Welcome to my high yield anatomy review series for the USMLE Step 1 NBME CBSE and NBME CAS examinations. This will be part 25 of my multi-part video series, giving a broad overview of anatomy for these exams. So without further ado, let's go ahead and get started on today's content. So I'd like to open up today by talking about Meckel's Diverticulum. Meckel's diverticulum is an inborn anomaly characterized by a persistent segment of the vitilo-intestinal duct. Typically, it remains asymptomatic, but through inflammation, though inflammation can occur, especially when it contains misplaced gastric, pancreatic, or endometrial tissue, potentially leading to ulceration. This condition affects around 2% of individuals and is positioned approximately 2 feet before the junction of the ileum and cecum, measuring about 2 inches in length, which is about 5 centimeters. Clinical significance arises due to potential complications such as diverticulitis, perforation, bleeding, liberation, and obstruction, which often necessitate surgical intervention. These complications frequently present symptoms akin to acute appendicitis, adding to the diagnostic challenge. And I have a nice visual representation of the issue to the right. Moving on. Features of the large intestine. They come with epiploic appendages, also known as omental appendices. They have saculations, also known as hostrations. They have tannae coli. The tannae coli coverage at the base of the appendix, where they unite to create a continuous longitudinal muscle layer encasing the appendix. All of these can be seen on the picture to the right. Moving on. We have pain of appendicitis. In cases of appendicitis, initial pain manifests as referred discomfort around the umbilicus. Visceral pain associated with the appendix arises from either the distension of its lumen or muscle spasms. The sensory fibers conveying this pain enter the spinal cord at the T10 segment, resulting in a diffuse referred sensation experienced in the umbilical region. Subsequently, if the inflammation affects the parietal peritoneum, the pain shifts laterally towards McBurney's point. At this stage, the pain becomes sharp, intense, and pinpointed, characterized as the second pain. I have a nice picture of appendicitis to the right for your visual aid. With that, let's go ahead and move on to some questions. A 28-year-old male presents to the emergency department with acute abdominal pain localized to the right lower quadrant. Physical examination reveals tenderness upon palpation and rebound tenderness in the same area. Laboratory investigations are notable for leukocytosis. Imaging studies demonstrate an inflamed structure located about 2 feet proximal to the iliacoccal junction, measuring approximately 2 inches in length. Which of the following is the most likely diagnosis? Alright, I think I gave you guys enough time here. If you need more time, please feel free to pause the video. Otherwise, moving on now. Meckel's diverticulitis typically presents with acute abdominal pain localized to the right lower quadrant, mimicking the clinical presentation of acute appendicitis. It commonly occurs around 2 feet before the iliacoccal junction and measures about 2 inches in length, as described in this patient. Imaging studies often reveal an inflamed structure consistent with Meckel's diverticulitis. Therefore, the correct answer is B, Meckel's diverticulitis. Let's go ahead and see why the other answer choices are incorrect. Acute appendicitis is a common cause of acute abdominal pain localized to the right lower quadrant, but the location of the inflamed structure described in this question is more consistent with Meckel's diverticulitis. Crohn's disease can also present with abdominal pain and inflammation. but it typically involves a more extensive segment of the gastrointestinal tract and does not manifest as a localized structure in the right lower quadrant. Ileocecal intussusception or intussusception is characterized by telescoping of a proximal segment of the intestine into the distal segment, leading to obstruction and abdominal pain. However, Meckel's diverticulitis is a more likely diagnosis based on the description provided. Gastrointestinal bleeding can be a complication of Meckel's diverticulum, but it typically presents with symptoms such as melena or hematochezia, rather than acute abdominal pain and tenderness as described in this case. Let's go ahead and move on to the next question. A 45-year-old presents with abdominal discomfort and bloating. Imaging studies reveal characteristic features of the large intestine, including epiploic appendages, saculations, and Taenia coli. Which of the following functions is most closely associated with the structure formed by convergence of the Taenia coli at the base of the appendix? Alright, I think I gave you guys enough time here. If you need more time, please feel free to pause the video. Otherwise, moving on now. The convergence of the Taenia coli at the base of the appendix forms a complete longitudinal muscle coat around the appendix. This muscular arrangement serves to constrict the appendix during inflammation, helping to prevent the spread of infection and containing the inflammatory process locally. Therefore, the correct answer is D, constriction of the appendix during inflammation. Let's go ahead and see why the other answer choices are incorrect. Absorption of water and electrolytes primarily occurs in the colon, particularly in the distal segments, rather than at the base of the appendix. Facilitation of peristalsis is associated with the muscular contractions of the intestinal wall, which are more related to the muscular layers of the colon rather than specific structure formed by the convergence of the Taenia coli at the base of the appendix. Formation of haustral contractions is facilitated by the saculations or haustrations of the colon, rather than convergence of the Taenia coli at the base of the appendix. Promotion of bacterial fermentation primarily occurs in the colon, particularly in the cecum and ascending colon, where bacterial flora are abundant, but is not directly related to the structure formed by the convergence of the Taenia coli at the base of the appendix. Moving on. Next question. A 32-year-old patient presents to the emergency department with abdominal pain. Initially, the patient describes discomfort around the umbilicus, which later becomes severe and localized to the right lower quadrant. Which of the following best describes the mechanism underlying the initial referred pain in appendicitis? Alright, I think I gave you guys enough time here. If you need more time, please feel free to pause the video. Otherwise, moving on now. In appendicitis, the initial referred pain around the umbilicus is attributed to the activation of visceral pain fibers at the level of T10 as the afferent pain fibers from the appendix enter the spinal cord at this segment. This results in a vague and diffuse sensation felt in the umbilical region before the inflammation progresses and affects nearby structures. Therefore, the correct answer is C, activation of visceral pain fibers at the level of T10. Let's go ahead and take a look at why the other answer choices are incorrect. Direct irritation of the parietal peritoneum typically occurs at a later stage of appendicitis when the inflammation extends to involve the outer layer of the appendix, leading to localized pain at McBurney's point. Somatic pain fibers in the appendix are not typically involved in the initial referred pain. Rather, visceral pain fibers are responsible for the initial discomfort felt around the umbilicus. Compression of the iliohypogastric nerve would result in sensory deficits or pain in the lower abdomen or groin area, rather than the characteristic referred pain pattern seen in appendicitis. Irritation of the phrenic nerve primarily causes referred pain in the shoulder or upper abdomen, unrelated to the typical presentation of appendicitis. Guys, that will do it all for this video today. A nice review of GI anatomy. So if you have any questions, comments, or concerns, please feel free to leave them in the comment section below. I'd appreciate it if you guys could leave a like and subscribe for more content like this. But anyways, this is FixerMed signing off. Be sure to have a great day, everyone. Good luck studying, and goodbye.